we've come to the, last talk. We are just cutting short with Vignesh. Vignesh, yeah.
Yes.
We started 10 minutes late, so I think the organizers have given us 10 minutes extra time.
So good morning. I thank Giridhar sir for this opportunity. CSCR management, like many times, the treatment of chronic CSCR is challenging despite many therapeutic agents or laser procedures. Is there a role of eplerenone or spironolactone in the treatment of CSCR? So let us see on that. So the involvement of the mineralocorticoid receptor pathway in the pathogens of CSCR was identified in animal model. Intravitreal injection of aldosterone resulted in choroidal thickening. And to prove their point, the researchers here treated two patients of persistent CSCR with eplerenone for 5 weeks, and there was a complete resolution in 5 weeks, and it persisted for another 5 months. The first pilot study again studied on eplerenone in CSCR, which resulted in significant reduction in central macular thickness, SRF level, and improvement in visual acuity. And then there was another study on spironolactone, where patients were treated with spironolactone 25 milligram twice daily, 12 weeks, had a very good reduction in SRF as well as improvement in vision. And another study compared spironolactone with eplerenone. Spironolactone was superior to eplerenone in terms of BCVA improvement. However, both drugs were equally effective in reduction of subretinal fluid. The first randomized double-blind placebo-controlled trial showed that the treatment group with eplerenone had a significant improvement in visual acuity and SRF reduction. So they concluded that it's safe and potentially effective, the treatment of chronic CSCR with persistent SRF. Then again, another major review of literature on the treatment of eplerenone, treatment of CSCR with eplerenone concluded that oral eplerenone at a dose of 25 to 50 milligram per day was effective and well tolerated for the treatment of chronic CSCR. Significant improvement in visual acuity and decrease or total absorption of SRF was noted in these studies, and patients presenting widespread RP changes were less likely to benefit. However, a major blow came to because of this study called the VC. So they concluded that eplerenone was not superior to placebo for BCVA improvement in people with chronic CSCR after 1 year of treatment, and even they recommended that not to use eplerenone for chronic CSCR. However, this study had some limitations, like these authors have discussed. Like they considered as a high baseline BCVA of 6.9. Functional outcome like BCVA was used instead of as a primary endpoint instead of the anatomical outcome. A rebound effect was not accounted. SRF thickness was measured instead of SRF volume. And these authors concluded that VC study to stop prescribing eplerenone for chronic CSCR is too severe. So eplerenone is a aldosterone antagonist type of potassium sparing diuretic. It's a selective aldosterone receptor antagonist. So unlike the spironolactone, which interacts with the hormonal receptors leading to hormonal side effects, eplerenone does not have that. Even though it is less potent than spironolactone, it is approved for use in the treatment of hypertension and heart failure. Hyperkalemia is a serious adverse effect, but it is not commonly seen. Other minor adverse effects include headache, drowsiness, dizziness, body ache, and tiredness. So before starting eplerenone therapy, it is advisable to have a baseline renal function test, liver function test, and most importantly, serum potassium. Eplerenone is started only if the above parameters are within normal limits and there are no systemic contraindications. So I always advise efficient fitness to be taken before prescribing eplerenone. Serum potassium to be monitored in the first week and every month follow-up. Eplerenone in a dose of 25 milligram once daily is started for a week, and there are no adverse effects reported by the patient, or the serum potassium remains within normal limits. Dosage is increased to 50 milligram once daily and continued until there is resolution. So the OCT predictors of eplerenone therapy are thicker subfoveal choroidal thickness, smaller subretinal fluid maximum diameter, lower number of serous PEDs, and lower number of intraretinal hyperreflective foci are significant predictors of complete SRF resolution at 3 months with the treatment of eplerenone. So let us see in various CSCR, various classification of CSCR, like acute CSCR, there is a greater and faster resolution than observation, faster visual acuity improvement, and even SFCT in the fellow eye was reduced. So in this case, we can see a 47-year-old male patient, defective vision of 1 month duration and vision of 6.9, but there is no leak on the FFA except for the PED seen in along the superior arcade. But you can see here a complete resolution within 15 days of starting the treatment. So another case where there was subretinal fibrin with a leak, this fibrin just melts. We can see in 1 month time there is a very good reduction and almost near resolution of the SRF along with the fibrin. In chronic CSCR, significant improvement in BCVA as compared to placebo. improvement in CMT and SRF levels in the eplerenone treatment, whereas it worsened in the placebo group. So in this study done by me and my colleagues, we compared micropulse laser with eplerenone. These were really chronic cases with widespread RPE changes. We observed in this study micropulse laser to be superior to eplerenone. However, we had improvement of complete SRF resolution was seen in 42.8% in micropulse group and 20% in the eplerenone group. So compared to half-dose PDT, the SPECTRA trial. So here they have shown that half-dose PDT is superior to eplerenone both in safety and outcome, both at the 3rd month as well as the 1-year follow-up. However, there was another study where in chronic CSCR refractory to PDT, eplerenone was beneficial. So in this case of a chronic CSCR, a 45-year-old male patient, defective vision of 4-month duration, we can see the leaks here. Very good resolution, very good decrease in 1 month and complete resolution by 2nd month with improvement of vision from 612 to 69. There's another case, this 52-year-old male patient had defective vision right eye of 6 months duration. We can see small PEDs. I ruled out neovascularization. And see here, the no SRF in 12 days. The SRF was there for 6 months, more than 6 months, according to the patient for symptoms. But here it resulted in no SRF in just 12 days with PED still persisting. So again, CSCR with CMD. Here also, we have tried eplerenone. There have been some reports of good decrease. So in this case, we can see IRF with subretinal fluid. There was complete resolution and vision improved from 612 to 66. And it persisted for at least another 6 months after stopping the therapy. In this case, again, there was a decrease in both SRF and IRF with eplerenone. However, it doesn't act in every case. But this case here, a 48-year-old male patient, defective vision in right eye for 13 years. So the chronic CSCR of 13-year duration, we can see the cystoid macular degeneration. There was some decrease, but however, again, it came back along with the treatment. So in bullous CSCR also, it has been tried. So I'll just share my cases. Here, a 30-year-old male patient, BCVA of 3/60, defective vision of 2 months. It was treated as macular choroiditis elsewhere with oral steroids. But once the oral steroid was started, the patient himself stopped because it worsened. So he came to me with this stage. You can see here, this is I called a melting of subretinal fibrin. Whenever there is fibrin, my first choice will be eplerenone. Another case, here again the bullous CSCR, 45-year-old male patient, defective vision of 2 weeks duration. We can see multiple leaks as well as fibrin and the inferior bullous detachment in the B scan. So what I did was I treated with eplerenone. After 2 months, there was fluid. So what I did, I additionally added micropulse laser to hasten the recovery. So here we can see a complete recovery of bullous CSCR with both eplerenone and micropulse laser. Micropulse was done after decreasing the leaks with eplerenone and thereby achieving the complete resolution. We can see even the inferior bullous RD resolving in 3rd month and the macular fluid resolving at 4th month. So to conclude, eplerenone is beneficial in the treatment of all types of CSCR. There are no safety issues except for hyperkalemia, which is uncommon. But however, we have to screen the patient before starting, make sure that they are fit. Efficacy is lesser in long-standing cases of CSCR with features of chronicity. Eplerenone may not be effective in cases where the risk factors are not eliminated or reduced. If the patient is already on steroids, again, if you give eplerenone, it may not be effective. And in all cases of CSCR, it may not be effective because we have studies on the genotype, the genes involved in the mineralocorticoid pathway. Different haplotypes of the gene involved in the mineralocorticoid receptor may be associated with severity in CSCR cases. However, we need prospective long-term RCTs comparing eplerenone with other modalities. Thank you.